for the cardiac output representation, and because we're using something that's red, I certainly did not want that anywhere except for this kitchen table. So I'm going to have my son do a little demonstration to kind of help you understand a little bit about cardiac output. Wait until I say go.
Okay.
Okay, so the first slide that you see here has got a couple of different YouTube videos on it for your viewing pleasure. If you so choose, you do not have to watch those. But if any different components of this particular portion of the PowerPoint seem a little confusing to you, those videos may be of help. So whenever we're looking at cardiac output, what we are going to be referring to is a particular formula that you are going to want to remember. This formula is CO equals HR times SV. That stands for heart rate times stroke volume. And those two things are going to be multiplied together to give us what we refer to as cardiac output. This is the volume that gets pumped out by the left ventricle in 1 minute. Now, this also happens on the right side as well, but we really want to measure it on the left side because remember, left side is going to the entire body. So that is why the left side of the myocardium is a whole lot thicker, because that blood has to go a whole lot further, whereas the right ventricle, the myocardium, is thinner because it only has to pump blood out into the lungs. So the cardiac output is going to be the same for both of these, but we always refer to left ventricle because we want to understand how the rest of the body, the systemic circuit, is being nourished with oxygen and nutrients. So my son is going to do the example. What we have here, move this computer back. On the table is we have this bowl. This bowl is going to represent your body. Okay, so think about this bowl as the body. And then we also have some tomato juice, which is going to be the blood. And he's going to be utilizing this measuring cup. This measuring cup he's going to measure out at the 1/3 cup line, because that's going to give us around the 80 milliliters that we would need to represent stroke volume. So he is going to fill the 1/3 measuring cup with this blood and then dump it into this bowl as many times as he can in 1 minute. So how much blood is able to get to the body in 1 minute is what we're going to be doing. So, okay, have a seat.
Okay.
Okay, so I'm going to time him, and I'm actually only going to time for 30 seconds, and then we'll just multiply by 2. So let me get the timer up.
Okay,
okay, so you know what you're going to do, right? Okay, here, put this closer to you so it doesn't spill. All right, 30 seconds on your mark, set, go. As fast as you can. Maybe hold that black thing over the bowl. There you go. And stop. Okay, so you went all the way through with the entire thing. How many times did he dump?
9.
9 times? Okay. Thank you, son.
I helped.
Okay, so my daughter was counting how many times he, my daughter is so intent upon being on this video today. No. Okay, so my daughter counted how many times he dumped into the bowl. So that was 9 times. So in this particular instance, the heart rate is how fast he moved. So 9 times for the heart rate, the stroke volume, which was 80 milliliters, which is what he filled that 1/3 cup up with. So if we do 9 times 80, what is that?
What's 9 times 80? It's 700.
The answer is 720.
720 milliliters per minute is how much TJ was able to actually put into the bowl. Okay, so that's how much blood got into the body. 720 milliliters in his minute. So here's what I want you to understand. When it comes to cardiac output, the normal heart rate is around 75 beats per minute, and stroke volume still being that 80 milliliters per beat. That equates to 6,000 milliliters per minute. So it's a good thing that he's not our heart, because although he's great at a whole bunch of things, 720 milliliters per minute is just not going to cut it. That is not going to get enough oxygen and nutrients to all of the tissues in order to saturate them and keep them healthy. 720 milliliters per minute is going to equate to death eventually. So this heart is amazing in how fast it can move and how adequate it can ensure that we maintain what we call tissue perfusion. So thank you, son, for your help. I appreciate it. Thank you, Charisma, for your help. I appreciate it.
I did the counting.
Okay, here, throw this in the sink now. That
Okay.
goes down the drain. Okay, so what are the factors that could then alter this? Because obviously you could see that my son, if he kind of altered the fact that he had the black measuring cup above the bowl, that's a little bit different versus sitting it beside the bowl. What can alter the heart rate? And then also, are there things that have the ability to alter the stroke volume? From my position where I was standing, I could see that sometimes he poured a little bit more than that 1/3 milliliter, or excuse me, that 1/3 cup, sometimes a little bit less. So that's going to change the milliliters that are actually going into the body. So yes, there are factors that can affect that stroke volume as well. So if we're looking at heart rate, the factors that can affect that particular rate are going to be, of course, the autonomic nervous system. So the question mark is because if you do not know the two different divisions of the autonomic nervous system, then you want to make sure that you go back and you look at those things. We're going to be talking more about those today. Hormones, epinephrine, norepinephrine, and then thyroid hormones can all alter heart rate as well. And we'll be talking about that a little later. Now, the two factors that can affect stroke volume include the EDV and the ESV. We talked about the EDV and the ESV a little bit in part 2, but I just want to do a quick recap so that way we are definitely all on the same page in regards to that EDV and that ESV that you recently learned. So for our EDV, remember this stands for end diastolic volume. I had you guys do the representation with your hands to represent the hands being in a relaxed state. So this is representing diastole. So however much blood is in the ventricles whenever they have been completely refilled as they're in their relaxed state, that's going to be your EDV, your end diastolic volume. Remember, whenever you squeeze the hands, you contract them, that is representing systole. And whatever splashes you in the face, remember that is technically your stroke volume. So the stroke volume was what my son was just pouring into that bowl. So that was splashing into the bowl. Okay? So ESV, remember, this is what is left in the hands after systole has occurred, or what is left within the ventricles after the blood has ejected out of the semilunar valves. So remember, this is about 40% of the EDV. However much blood gets ejected, that's the stroke volume, is going to be very, very, very important, because that is the amount of blood that can then go on to all of the other different body tissues in order to saturate them with oxygen and nutrients. So it's very important that that stroke volume be at least 55% or 60%. So for you words people, there's your word slides right there. It says the exact same thing that I just said on the picture. So this is how we determine our stroke volume, the EDV minus the ESV. Okay, so let's go back and talk a little bit deeper in regards to the factors that can affect the heart rate for the autonomic innervation. Remember, parasympathetic will be for our rest and digest side, so it's going to slow the heart rate, whereas sympathetic is going to increase it, because that's going to be during your times of fight or flight or freeze stressful events. Hormones, we've already said that. Now, fitness levels and age, that's something new on this slide. Depending upon your fitness level will depend upon how fast or slow your heart actually beats. And of course, for your age, that is also going to change your heart rate as well. I'll show you a slide here in just a second that will basically point out fitness levels and age in regards to the variability in heart rate. Factors that can affect stroke volume are going to be anything that has the ability to affect ultimately the EDV and the ESV. And so there is your different things that can affect EDV and ESV. We're going to talk about these things as we kind of go through some of these slides on this PowerPoint. Ultimately, the body is going to adjust your cardiac output in order to make sure that as conditions change, there is sufficient amount of blood to provide to your tissues. You are not going to have the same cardiac output while you are sleeping as you would while you're running a 5K. Obviously, everybody kind of has a course. Everybody knows that. So when we talk about cardiac output, sometimes students get a little bit confused, I think because there's so many new terms as well as formulas. And then we also have all of these things that can change whenever different situations arise. So if you start to get confused because of all of the new things, then just take a moment, take a break, take a step back, and just think about it from a more logical standpoint, so that way it can kind of get ingrained into your brain. So here is your charts that are going to show heart rates for age as well as fitness level. Whether you're a man or a woman, you can look at the first two on the left-hand side to determine, based upon your age and then your fitness level, where should your heart rate be. Now for me, I'm going to be within the 36 to 45 category on women. I'm not an athlete, probably not even in excellent condition because I don't spend enough time exercising. So my goal for me would be to be in the good category. So somewhere between 65 to 69 beats per minute is what I kind of want to be looking for. Now, if I go and I evaluate my heart rate after this and I find that it is much higher than that, then I'll just go cry in a corner by myself, I guess. No, I'm just kidding. I'll go exercise, okay? So if you look at the little chart on the right-hand side, that is target heart rate for exercise. So there are formulas that you can utilize in order to kind of figure out what is my target heart rate, kind of what is my maximum heart rate, where should I be working at in my activity, in my exercise, in order to achieve any goals that I have. It's going to be different depending upon your health and your age as to what goals you have to determine where you want your target heart rate to be. For the bottom chart, what you can see there, if you look at that one-year-old heart rate is 153.5 beats per minute. That's really, really, really high. So whenever you're thinking about little babies, the reason why they have a higher heart rate is because their hearts are smaller. So if you have a little bitty tiny heart, not a lot of blood can get into that heart. So it's going to have to beat a whole lot faster on a more consistent basis in order to continue to push blood all around the body. As they grow and their heart enlarges, then of course you can see that that heart rate is going to go down because the pump becomes more efficient as it gets bigger, okay? All right, so let's talk about the autonomic innervation. We're talking about the cardiac plexus, which will innervate the heart, and within the medulla of the brain, you have the cardioacceleratory centers as well as the cardioinhibitory centers. The acceleratory center is, of course, going to control the sympathetic neurons that are going to allow the heart rate to increase, and then the inhibitory will control the parasympathetic neurons that will cause the heart rate to decrease. There is dual innervation in the heart, which means that both of those are going to always be going to the heart, and they will release either the acetylcholine or the norepinephrine at the nodes that you learned about in part 2. The acetylcholine is, of course, going to be released by the parasympathetic neurons, which will cause the heart rate to slow, and the norepinephrine will be released by the sympathetic neurons, which will cause the heart rate to rise. Here's a picture so that you can actually see the medulla. You can see everything that I have in the circle is going to be related to the parasympathetic side. Because the parasympathetic side is more dominant in a healthy individual, this quite naturally will decrease our heart rate. So even though we could have a heart rate For the SA node being the pacemaker at up to 100 beats per minute, the parasympathetic side is more dominant and it therefore will slow down that heart rate. You can see if you kind of trace along the vagus nerve as well as the cardiac nerve and ultimately end up in your nodes, you can see there is that dual innervation there. So both of them are going to be supplying both of those nodes. The little black arrows that are blank, that's just there for you to remember. The SA node is going to be the one that is closest to that superior vena cava. Remember, it is the pacemaker, the one that is setting the pace, and it will send its electrical signal down into that AV node. SA node is always going to be faster. It will spontaneously depolarize quicker, which is why it's what gets to set the pace. But again, because the parasympathetic naturally slows the heart rate because of the acetylcholine, this will bring the heart rate down. Effects of pacemaker cells on the SA node. You have the membrane potentials of those pacemaker cells closer to threshold than those of the cardiac contractile cells. That's just a recap from some of the stuff that we talked about in part 2. So anything that will change the ionic permeabilities of cells in the conducting system will change the rate of spontaneous depolarization, which will then in turn alter the heart rate. So anything that can change ion levels, whether that's sodium, calcium, etc., that potassium, those things will then alter the nodes, the spontaneous depolarization, and then can affect the heart rate itself. If you look at this slide right here, what I want you to pay attention to before you try to figure anything else out is I want you to look at the purple shading underneath the threshold line. So look at the purple shading underneath the threshold line and just see about how big that purple shading is. So this is in a normal resting heart. These pacemaker cells, remember the cells that are autorhythmic, the ones that spontaneously depolarize. Whenever we look at their plasma membranes depolarizing to threshold and producing the action potentials, this is the funky little graph that we get whenever we put this on a chart. Does not look like the cardiac contractile cells that we talked about in part 2. This graph looks very different. So that's why I want you to turn your eyes to the purple area. If you compare that purple area with this purple area, now you can see that there is quite a difference. So on this particular chart, this is representing parasympathetic stimulation. This is normal and resting. This is parasympathetic stimulation. So what happens is those nerves will release that acetylcholine, and that's going to open up potassium channels. So potassium will leave the pacemaker cells, and the highlight here is that it extends repolarization. As it extends repolarization, that means that this decreases the rate of spontaneous depolarization. Okay? If you extend repolarization, then you are going to decrease the ability for that heart rate to have another action potential. It's going to be slower, and so then the heart rate is going to slow down. That is how the parasympathetic stimulation will alter the levels of depolarization and repolarization. Versus if we look at sympathetic stimulation, now when we look here, you can see that this chart looks different again, and still looking at the purple, now we have a whole lot less purple, because what's happening here is that sympathetic stimulation will release that norepinephrine. That norepinephrine will bind to the beta-1 receptors, and that is then going to open up sodium and calcium ion channels, and it's going to shorten repolarization. As it shortens repolarization, then that means that it makes it easier for us to hit threshold again with another action potential and then accelerate the rate of spontaneous depolarization. So because of this, the heart rate is going to increase. So big forest picture is, if we're talking about parasympathetic stimulation, we're talking about acetylcholine and potassium channels. Potassium is going to extend repolarization time. As it extends repolarization, then it's going to decrease the rate of spontaneous depolarization. Okay? Extend repolarization, decrease the ability to have that spontaneous depolarization. This one, sympathetic, releases norepinephrine. Those beta-1 receptors are going to open up the sodium ion and calcium ion channels, and it's going to shorten repolarization. As we shorten repolarization, then what's going to happen is we're going to have a greater ability to hit that threshold a whole lot quicker, which is going to accelerate that rate of spontaneous depolarization and increase the heart rate. So that's how the two sides of the autonomic nervous system can affect the heart rate. This is everything that I've already said in word slide. Now, whenever we're looking at the cardiac centers, it's also important to note right here that we do have baroreceptors and chemoreceptors that are going to monitor blood pressure, oxygen, carbon dioxide, pH levels, etc., in order to adjust any cardiac activity as needed to maintain homeostasis. So I'm going to briefly go through the baroreceptors and the chemoreceptors. There's more information on those through the blood vessel PowerPoints. But for right now, I do want to kind of show you how that cardiac output can also change based upon what the baroreceptors and the chemoreceptors are saying. So if we look here, you can see that chemo, remember that's for chemical, chemoreceptor, a chemical receptor. These are going to sense any chemical changes within the blood. So like I said, the O2, the CO2, the pH, any chemical changes are going to be read through chemoreceptors. So we have chemoreceptors that are in the brain, in the medulla, chemoreceptors that are in the carotid artery, and then in the aorta. So all of this is going to talk to one another, and this is going to be automatic control. Obviously, if there's something going on internally, you may not even know it, but your brain and your heart may work together to help address anything that is not within that homeostasis like it should be. So we're monitoring O2, CO2, and pH, okay? So if, for example, if you look over on the left-hand side, you can see number 3 says decrease blood oxygen. So that's, you know, that's not good. We don't want to be hypoxic. That's too decreased oxygen levels. We don't want to be hypoxic. Increased CO2. We don't want to have that. Of course, that's too much waste that's building up. And then decreased pH. This is all going to decrease the parasympathetic stimulation. Remember, parasympathetic is to slow the heart. So if we decrease the parasympathetic stimulation, then that means we tell the parasympathetic system, stop trying to make this heart so slow. We want it to beat faster and beat harder. So whenever the chemoreceptors get an alert that oxygen is low, CO2 is high, and then pH is low, it's going to make the heart rate increase. And the reason why it's going to do that is because it's going to try to push more blood over into the lungs to pick up more oxygen and drop off more CO2, because we want to flip those levels. If we have a decreased O2 and an increased CO2, how can we make it to where we can have more O2 and less CO2? Heart pumps harder, faster, get more blood over there into the lungs, pick up more, and then get rid of more waste. So again, like I told you guys already, the heart and the lungs have to work hand in hand together. And that's one of the instances in which they will. Number 4, decreased blood O2, increased CO2, and decreased pH. All the same things that we just said. Increased sympathetic stimulation of the heart. So besides the fact that we decrease parasympathetic, we can increase sympathetic and do the exact same thing that I just went through. Or number 5, same thing, decrease blood O2, increase CO2, decrease pH. We can increase the sympathetic stimulation of the vessels, which will increase vasoconstriction. We increase vasoconstriction, we increase the blood pressure. By increasing the blood pressure, we can then increase the heart rate and still achieve all of the same goals. For baroreceptors, when you hear the word baro, you want to think about pressure. So these baroreceptors are going to pick up any changes within pressure. Again, in the medulla, again in the carotid, and again in the aorta. So these are going to check and monitor, is the blood pressure too high? Is the blood pressure too low? What can we do in order to return back to homeostasis as needed? So if we're looking at an example, I have it written out for you, vomiting and diarrhea. In vomiting and diarrhea, what's happening is you're losing lots of fluids. As you lose fluids, then you're going to have a decrease in blood pressure. Why? Because your blood plasma is 90% water. And if you're losing lots of fluids, then your pressure is going to go into the tank as well. So the baroreceptors can sense this change, and they can increase the sympathetic stimulation in order to help bring that blood pressure back up, as it does all of the things like increasing the heart rate, constricting the vessels, things of that nature. If you've ever been sick and you've ever been, like head over a toilet, you're like hugging the toilet, got it completely wrapped around you. I've only been there a few times in my life, thank God. Throwing up is not my thing. But if you've ever had that happen and you've ever been really, really sick, and whenever you go to stand up, if you start to feel a little bit dizzy or woozy, and then you start to feel your heart palpating really, 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 really fast, what's happening is those baroreceptors are kicking in, and as you attempted to stand up, they realized, okay, in order for this person not to completely pass out, we're going to have to increase the sympathetic stimulation. We're going to have to do some vasoconstriction, increase in the heart rate, so that way we can get blood up into the brain, get blood everywhere else in the body. As that pressure is kind of starting to drop, we need to bring it back up. So that's actually what's happening there in that particular case. So that's how baroreceptors work in order to help you maintain your homeostasis within your heart rate. There is a thing that's called the Bainbridge reflex. This is an atrial reflex, and technically it's a baroreceptor reflex. At this point, it's not just about pressure, but it's also about the increase in the venous return. So in part 1, you learned that there are 3 ways for deoxygenated blood to get back into the heart. So SVC, IVC, coronary sinus, all are going to dump off into the right atrium. So there are stretch receptors in that right atrium that will trigger an increase in heart rate by stimulating that sympathetic activity if there is an increase in the venous return. And what this is going to do, by stimulating that heart rate, it's going to work on decreasing the pressure within those veins, the superior inferior vena cava, in order to help draw more blood out of the right atrium. So then that will drop the pressure within the right atrium, and that is going to help relieve some of the pressure within the veins. So in addition to the pressure, we're talking about venous return. So if you have a whole lot of venous return all at one time, this Bainbridge reflex may kick on, because what we don't want to do is, blow out the right atrium because there's so much blood rushing in all at one time. So let's increase the heart rate, hurry up and get it out of the right atrium so that we can get things back into normal homeostasis. There are other things that can change heart rate. For those things that increase the heart rate, we're going to call those positively chronotropic. Positively chronotropic. Anything that will decrease the heart rate, we're going to call them negatively chronotropic. Any factors that will strengthen the heart contraction, so now we're talking about the actual muscle force, the contraction of itself, we call those positively inotropic. And anything that will weaken the heart contraction, call it negatively inotropic. So if you look at this chart, basically it will tell you what is the definition of inotropic, chronotropic, and then there's also dromotropic. So there's different things that can affect the heart. Different drugs will work in these areas depending upon what needs to happen with the person, whether we need to slow the heart rate, increase the heart rate, strengthen the contraction, whatever it is. There's lots of different ways that you can look at this chart and utilize it whenever you are in the clinical field. Okay, so now that we've gone all through heart rate, remember, just to recap, we talked about fitness levels, have the ability to change the heart rate. The higher your fitness level, the greater your exercise regimen, the more athletic you are, the lower your heart rate is going to be, specifically because your pump is more efficient. The more out of shape you are, then the worse off your heart rate is going to be. It's going to be a lot higher because that is significant for the fact that your pump is not as efficient. So fitness levels, age, what heart size, we've got baroreceptors, chemoreceptors, all kinds of things, the autonomic nervous system, that can change your heart rate. So that is the first part of the equation for cardiac output, which is heart rate. Stroke volume is going to be the second one, because remember, it's HR times SV equals CO. So factors that affect stroke volume would be any changes in EDV or ESV. Of course, if you change those two, you're going to change the SV, which means you're going to change the cardiac output. So two major factors that will affect the EDV, this and diastolic volume, how much blood is there when the ventricles are relaxed, include filling time and venous return. So filling time is how long does it take for those ventricles to fill with blood. Of course, this depends entirely upon the heart rate. The faster the heart rate, the shorter the filling time. So if you are exercising and your heart rate is going fast, then what's actually going to change within your cardiac cycle is going to be the time that you spend in diastole and the ability to refill. So that's going to decrease. Venous return is how much blood is coming back into the right atria. So those two factors, of course, however much you get back is of course going to then affect how much is actually going to end up in the ventricles as they are trying to fill. So filling time and venous return are the two things that will affect that EDV. The Frank-Starling principle, basically, this is almost kind of like a common sense thing, but I'm going to kind of walk through it with you and hopefully explain it enough to where you feel like, oh yeah, that totally makes sense. The Frank-Starling principle says that as the EDV increases, okay, so your end diastolic volume, the more volume of blood you have in the ventricles in their filling time, as that increases, then your contractile strength increases and therefore stroke volume increases. So let's walk through that for a little bit. Let's say, for example, I have my kids come to me. This happened years ago, so not anymore now, but years ago when my kids were little, they would come to me and they would say, I can't blow up this balloon, right? So they have this balloon that's in their hands and they cannot get all of the air into the balloon. And now they want me to do it. Problem is, it's covered in slobber and I don't want to put my lips on that. Like, that's just gross. So that's besides the point. If I tell them, go get me a different balloon, and I blow it up, the EDV is increasing because I am able to put more air into the balloon. Now, because I have stretched the balloon further, it's more likely to make a really loud noise if I'm going to let that air out. And there's a whole lot more air that has the capability to come out. Whereas if I compare that to the little, scrotal sac looking balloon, that's all I could think about. The little balloon that looks like a little scrotal sac, it's not a lot of stretch to it. There's not a lot of air that can come out. So basically, Frank-Starling principle is more in equals greater strength equals more out, is what it's saying. So there are physical limits to this because the ability for those ventricles to expand is of course limited by that myocardial connective tissue we saw in part 1 and the cardiac skeleton and the pericardium. So all those three things that we saw that kind of surround the heart, they add the strength to the heart, but they also prevent overexpansion of the heart. So it's not like you can have a ton of EDV and have this big, huge, massive thing occurring. That's not going to happen. So there are physical limitations, but essentially Frank-Starling, the more blood that can come in, the greater the stretch we have, and the greater the stretch that we have, the stronger that heart can beat. The stronger the heart beats, the more stroke volume gets to come out and splash you in the face. Okay, so that will increase your cardiac output. Okay, so this is kind of similar to what I just said. At rest, if your EDV is low, then you don't have a lot of myocardium that is being stretched. Therefore, your stroke volume is going to be relatively low. So that's the comparison of the little balloon that could not get blown up that much. And then with exercise, you have the larger balloon. Now you have a whole lot more blood that's returning to your right atrium a whole lot quicker, which means your EDV is going to increase since your venous return increased. That stretching is going to cause the cells to be a whole lot more efficient in their contractile process and increase that stroke volume. Okay, so now that we've kind of walked through all of that, if you can answer this question, you're in a good place. If you can understand what's happening with filling time or venous return and how it directly affects the EDV, then you got it, okay? So for those of you who are like, I don't know, I am maybe not there. Let's walk through it one last time. Filling time. How much time do you have in order to get as much blood as possible into those ventricles? Venous return. How much blood is actually coming back into the right atrium that will then allow for that refill of the ventricles? So if your filling time increases, you get more time to fill, or your venous return increases, you get more blood that is going to fill, then your EDV increases. Is that true or false? I'm gonna give you a second. Wish I had my water cup. So if you answer true, then you're good. Because if you have a greater filling time and greater venous return, then yes, you are going to have an EDV that will increase. So that then makes the second equation true as well, because it's just the opposite. If the filling time or venous return decreases, then EDV is going to decrease. Therefore, stroke volume will decrease. Okay, so we talked about EDV, filling time, venous return is what affects EDV. ESV, so remember, after we go through systole and we squeeze, the stroke volume comes out, hits you in the face. So the ESV is the amount of blood remaining, that's your fill in the blank, remaining in the ventricle after this contraction has occurred. How much blood is basically left in my hands. So the things that are going to affect how much blood is remaining in that ventricle after contraction are going to be these three things right here: preload, contractility, and then afterload. So preload, we already talked about a little bit whenever we went through the Frank Starling. So this is the stretching of the ventricle as it is trying to fill. Of course, that means that this is going to be directly proportional to the EDV, as we've already discussed. But the better stretch, just like the bigger balloon, will lead to more tension. So that is what we call preload. How much are we loading up these muscle cells to allow them to have what's next, which is contractility. So the contractility is the force that is actually produced during contraction at a given preload. So preload, you think about that, think about what I underlined in green, stretching, okay? Contractility is force. Of course, this is going to be affected by the sympathetic and the parasympathetic side, as well as hormones, because these things can in turn affect your contractility. If contractility increases, then ESV decreases. So let's walk that through in our brain. If we have increased contractility, so let's say we have better preload, we have a better stretch. Therefore, because of our better stretch, we're going to have those muscle cells happy. The muscle cells want to be stretched, okay? They don't like to be lazy. So we have a better stretch, we have a better ability to contract, which means we're going to have a greater force. If we increase the force of contraction, then we're going to have a better stroke volume. And the more we have leave our heart, then the less is left right here in your hand when you're done. So that's why if contractility increases, then whatever's left in the ventricles is going to decrease. So I hope that makes sense. And then lastly, afterload. This is tension that has to be produced by the ventricles to pop open those semilunar valves and get the blood out of the heart and into the pulmonary trunk and into the aorta. So remember, blood flows from a high pressure to a low pressure. So you're going to have blood that's sitting on top of those semilunar valves that are within the aorta and the pulmonary trunk, right? So blood is going to sit on top of that. The ventricles have to be strong enough to produce a tension that is going to allow those valves to pop open so that blood can move from high pressure to a lower pressure. So afterload will increase if you have increased resistance to blood flow out of the ventricle. So the example that I gave there is increased by vasoconstriction and decreased by vasodilation. Think about that aorta that sits on top of the aortic semilunar valve. If you have a constricted aorta, now this constricted aorta is going to have a higher pressure, and that means that the pressure within the ventricles is going to have to be greater in order to pop open that aortic semilunar valve because of that constriction. So if we dilate, then the pressure is going to be lessened within the vessel, and so it's going to be easier to pop open that semilunar valve and allow the blood to get out of the heart and into the aorta. So this is why afterload is all about how much tension do the ventricles need to produce in order to get that semilunar valve to pop open and allow blood to eject out. If the afterload increases, or excuse me, when afterload increases, ESV increases, and when afterload decreases, ESV decreases. So if we have an increased afterload, the reason why the ESV is going to increase is because remember, ESV is all about what's remaining in our hands, what was not able to leave the heart. So remember, stroke volume splash you in the face. What was not able to leave? If we have an increase in afterload, then it's going to be harder for us to have a good stroke volume and a good ejection fraction, which means that we're going to have more blood remaining left in these ventricles than we should. So an increase in afterload will increase that ESV. And if we increase that ESV, then that means that we decreased the SV. So I know that's a lot. There are some charts on here that are going to maybe help you a little bit with, if we do this, then what happens? If we do that, then what happens? So I did put those charts on there for you. You can walk through whichever chart you like best. Here's one where you can see if you have a change in venous return or if you have a change in filling time, whatever the situation is, you can look at the key to determine what is this ultimately going to do. Is this going to increase something or is this going to decrease something? So that chart is there if you like that and that makes sense to you, or there's this one right here. It will tell you what happens with your stroke volume based upon these different factors. So use whatever you like, whatever works best for you. So in summary, whenever we're looking at cardiac output, remember, we're trying to figure out, just as my son poured that tomato juice into the bowl, how much blood can we get out into the system every single minute? How much blood? That's our cardiac output. It's all dependent upon how fast is our heartbeat and what is the stroke volume, how much blood is actually coming out of the heart. So remember, the heart rate control factors are sympathetic and parasympathetic, hormones, venous return, baroreceptors, chemoreceptors, okay? Age, fitness levels, all of those things play a role as well. Stroke volume control factors are going to be anything that will change the EDV or ESV. What changes EDV is the fill time and the venous return. What changes ESV is preload contractility and afterload. All of those things together are then going to determine if we have a sufficient cardiac output. Remember, we have to have sufficient cardiac output for tissue perfusion. If we do not have sufficient cardiac output, we will not have tissue perfusion. Things will start to die, get necrotic, we'll have problems all over the place. Okay, so here's the last little chart for you. Again, you can use that one if you like that one better. Cardiac reserve, this is the difference between the resting and then the maximal cardiac outputs. If you're talking about a trained athlete and they're exercising at their maximal levels, then they can greatly increase their cardiac output. When you watch Lance Armstrong ride his bike through the rain or the hail or the wind or whatever he's doing, let's not take into account the blood doping thing. Let's just say because his heart is sufficiently pumping, he can increase his cardiac output in order to continue to provide the oxygen and the nutrients that his skeletal muscles need in his legs, that he needs in his fingers to grip that bike. So it can be really, really high when you're a trained athlete. However, it's not going to increase indefinitely. That's why even Lance Armstrong needs to take a break, because you cannot just keep going up and up and up and up and up and up and up. There is a limitation to this. So whenever you look at cardiac output, remember it's all about adjusting the output for that body at that particular point in time. Everybody has to eventually stop exercising, because at some point the heart rate, even if it continues to climb, that stroke volume is going to begin to drop. And if that stroke volume begins to drop, you're not going to adequately tissue perfuse. So I hope that makes sense. If you have any questions about anything, feel free to let me know. Have a wonderful rest of your day.